Hi, very good morning. I'm Dr. Janak Patel. Today we are going to discuss regarding another topic, that is hyperlipidemia. I'm MD general physician. I'm not an MD cardiologist. We'll be discussing on hyperlipidemia. This is mainly lecture oriented to fourth year students. So there are few terms which are commonly utilized: hyperlipidemia, hyperlipoproteinemia, dyslipidemia, hypertriglyceridemia, etc. So these are some of the terms which will be utilized commonly. As usual, we'll be discussing under common heading definition, etiology, pathophysiology, clinical features, investigations, differential diagnosis, treatment and complications. Hyperlipidemia means increase level or increase amount of lipids in blood. That is abnormal level of lipids in blood. A simple most definition. Dyslipidemia means presence of abnormal level of blood lipids and lipoproteins. It is diagnosed by using fasting lipoprotein profiles, and nearly 40% of the adults have got LDL level more than 130, and this is labeled as dyslipidemia. And hyperlipoproteinemia means increased level of lipoproteins in blood. To understand this, you should know that lipids is divided into three groups: cholesterol, triglyceride, and other components. Now, depending upon the etiology, we label them as a primary or secondary. If there is increased level of TG, triglyceride, then we call that as hypertriglyceridemia. But if there is increase in level of cholesterol, we call hypercholesterolemia, which will include total cholesterol, LDL, or low level of HDL. Depending upon this, it is further divided depending upon what is abnormal. So basically, hyperlipidemia means abnormal level of either cholesterol or triglyceride or combination of both. So hyperlipidemia is a major risk factor for atherosclerosis. So we'll try to understand that particular part. So either triglyceride is elevated, then we call it as a hypertriglyceridemia. If cholesterol is elevated, hypercholesterolemia. And if both are elevated, then we call combined hyperlipidemia. In some, lipoprotein disorders may elevate LDL alone, or there may be a marked decrease in level of HDL. So these are all permutation combination of abnormal level of different lipids. So if only cholesterol is elevated, it is increase in total cholesterol, and among those total cholesterol mainly LDL is elevated. In hypertriglyceridemia, it is only increase in level of triglycerides. This triglyceride will give rise to what we call as VLDL, very low density lipoproteins. And when both are together, we call it a mixed hyperlipidemia, where both cholesterol as well as triglyceride level are elevated and HDL level is low. So dyslipidemia are the disorders of lipoprotein metabolism, including overproduction or deficiency, either of the two. This may be triglyceride is elevated, total cholesterol is elevated, or high level of LDL or low level of HDL. Any permutation combination of this. So hyperlipoproteinemia is a metabolic disorder characterized by abnormal elevated concentration of specific lipoprotein in plasma, or we call in blood. Either it is elevated or it is low. Depending upon that, we label that as a particular specific lipoproteinemia. Lipids are insoluble in plasma when it is combined with specific protein. We call it apolipoproteins. Soluble lipoproteins are formed. We call chylomicrons, which are very rich in Tg. Then very low density lipoprotein, low density lipoprotein, and high density lipoprotein. And there is also one term called as intermediate density lipoproteins. So these are the different parts of lipoprotein during metabolism. And depending upon what is being elevated, accordingly you label that into different groups. Say chylomicron is very rich in Tg. VLDL is having less quantity of Tg, but still Tg is more than cholesterol ester. Then intermediate cholesterol ester is more than Tg. Then in LDL, cholesterol is much more than Tg. And in HDL, cholesterol is little just above Tg. And this is density of HDL is maximum, while chylomicron density is the lowest. Size of chylomicron is maximum, large, while HDL is the smallest size particle. And HDL is called as a good cholesterol, while all these are bad cholesterol. And apolipoproteins are considered as very bad cholesterol. So these are the diagrams showing you the density as well as different types of lipoprotein sizes, etc. So HDL is the smallest size, while chylomicron is size wise biggest. And density wise, this is highest density, while this chylomicron is lowest density. This shows you all lipoproteins, that is chylomicron and chylomicron remnants, VLDL, intermediate, low density, and lipoprotein A, and HDL, out of which these four and LDL cholesterol, these are atherogenic triglyceride rich lipoproteins. That will be VLDL and intermediate variety. And these two combined together becomes atherogenic lipoproteins. This is a good cholesterol. So all these four will be non-HDL cholesterol. So non-HDL cholesterol is atherogenic. So if you look in this diagram, VLDL, intermediate, low density, and lipoprotein A, they are atherogenic. While this is a good cholesterol which removes cholesterol from peripheral tissue. So it will help in reversal of atherosclerotic process. So if you look at HDL, it is called as a good cholesterol, while LDL is a bad cholesterol, and VLDL, which is a low density lipoprotein derived from Tg, it is ugly, and apolipoproteins, lipoprotein A, it is a deadly cholesterol, considered as a deadly cholesterol. Etiology wise, we divide into two big groups, primary and secondary. Primary accounts for 5%, which are genetic or familial, while secondary are because of multiple different disorders, and it accounts for 95%. So it is always said that always rule out secondary first. If secondary is ruled out, then we go for primary. In primary, it is divided into 5 big groups, type 1, type 2. Type 2 is divided into A and B, 3, 4 and 5. Type 1 is very rich in Tg. There are increased chylomicrons. Type 2A, that is cholesterol is increased, and lipoprotein LDL, low density lipoprotein, is increased. This is the most common variety. 2A and 2B are the most common variety. 2B is containing cholesterol with Tg, where LDL and VLDL are elevated, and it is the most common variety. 3 is rare. There cholesterol and Tg is elevated, but in this intermediate density lipoprotein are elevated, and that is a rare variety. Type 4, where Tg is elevated, and from Tg you get VLDL, so that is another common variety. So among common variety, 2A, 2B and 4 are most common, while 5, 1 and 3. So 1, 3 and 5 are rare. So these 3 are absolutely rare, while 2 and 4 are common. And in 4, Tg is elevated, and secondary to Tg, VLDL is elevated. While in 2, LDL and VLDL is elevated. 2B is almost identical, close to what we call as 4 variety. So these are the different varieties where you get abnormal lipoproteins. So type 1 is familial hyperchylomicronemia. Type 2 is further divided into 2A and 2B. 2A is mainly cholesterol which is being elevated, while 2B is cholesterol with Tg which is being elevated. So that is called hypercholesterolemia, familial variety. 3 is hyperlipoproteinemia, where you get increase in intermediate density lipoproteins, while 4 is triglyceride which is being elevated. So it is called hypertriglyceridemia. And type 5 is increase in chylomicrons with LDL, and it is a rare variety. You can see again Tg, so that will give rise to VLDL and chylomicrons. So this is almost a combination of 4 and 1. 4 and 1. So 5 is nearly 4 and 1. So indirectly we come across this 2, and this is the third variety. So if we take 2 as a combination, it is cholesterol with triglyceride, and 4 is pure triglyceride, where only VLDL is elevated. So this is hypertriglyceridemia. This is hyperlipoproteinemia. So 2 is hypercholesterolemia, and type 4 is triglyceridemia. As far as the acquired group is concerned, diet, diabetes mellitus, uncontrolled diabetes mellitus, where usually triglyceride level is elevated, obesity, cardiometabolic syndrome, chronic alcoholism, among drugs, beta blocker, hydrochlorothiazide, in nephrotic syndrome, chronic liver disease, particularly obstructive jaundice, oral contraceptive pills, and hypothyroidism. These are the most common condition which you will come across in your everyday practice. In hyperlipidemia or dyslipidemia, by and large the cholesterol level, total cholesterol level is elevated, secondary due to LDL elevation, and there will be low level of HDL. In triglyceridemia elevation, very low density lipoprotein level are elevated, and in some conditions ideal intermediate lipoprotein, dense lipoprotein level may be elevated. Or sometimes you can have a combination of both, where triglyceride and cholesterol both are elevated. This is more common in familial conditions, but in acquired also you can come across elevated level of triglyceride as well as cholesterol, and this will be very common in obstructive jaundice. In obstructive jaundice it is very common. Uncontrolled diabetes also it is very common. So 5% are primary, 95% are secondary. And these are the second common. We already told you where LDL level is elevated. Nephrotic syndrome, hypothyroidism, obstructive jaundice, anorexia nervosa, oral contraceptive pills, thiazides, anabolic steroids, etc. While TG, which is very markedly elevated, very common in diabetes, uncontrolled diabetes, oral contraceptive pills, beta blockers, pregnancy, steroid, thiazide diuretic, alcohol, uremia, smoking, etc. These are some of the other groups: diet, drugs, disease, disorders, elevated LDL, elevated TG. We already mentioned in previous slide. Most common in India because we Indian love food and our food gives rise to elevated level of TG, low level of HDL and high level of LDL. All are atherogenic. There are other factors also which influence hyperlipidemia like metabolic syndrome, obesity, abnormal level of apolipoproteins, lipoprotein A, homocysteine, inflammatory marker like C-reactive protein elevation, and genetic risk. And you can have any abnormality in any one of this. This is lipid level, that is TG as well as TC are abnormal, or you have got a high level of LDL and low level of HDL. And whenever there is a high level of TG, you will have a very low density lipoprotein being elevated. And when you calculate non-HDL cholesterol, it will be very high in a person who has got a LDL level being elevated. LDL level will be elevated. So in that group, you have got a non-HDL level being high, and you should calculate the ratio of total cholesterol to HDL or LDL to HDL, or even sometimes they calculate, if this is possible, apolipoprotein B to apolipoprotein A1 calculation are being done. In metabolic syndrome, there is a 200 times increased cardiovascular risk. Basically, this is called syndrome X or insulin resistance, or we call metabolic syndrome, where you've got a type 2 diabetes mellitus, impaired glucose tolerance, hypertension, insulin resistance, central obesity. They are having more chance of, female are having more chance of polycystic ovarian syndrome. There is increased level of uric acid, hyperuricemia. Insulin level are elevated, secondary because of insulin resistance, we call hyperinsulinemia. There is increased fibrinolytic activity. So this increases the chances of coagulation. There is a dyslipidemia, means TG is elevated, LDL is elevated, HDL is low. All this increases the chance of atherosclerosis and accelerated atherosclerosis. All these factors are having a very, very high risk for cerebrovascular disorders, as well as we can call atherosclerotic induced cardiovascular disease, ASCVD. There is one simple slide which is showing you, I will not say simple, it is a complicated slide, where you get signals from the brain. These are the factors which stimulates, these are the factor which inhibits. So this factor which stimulates will be acting on liver, adipose tissue, adrenal gland, pancreas, GI tract, etc. So these factors, GLP-1 and others, 5-hydroxytryptamine, etc. What they will have? They will have effect on food intake, and this will have effect on GI tract, adipose tissue and adrenal glands. While in peripheral signals, that is glucose, CCK, GLP-1, vagal stimulation, insulin, ghrelin, leptin, cortisol, adiponectin, etc. These are all the different peripheral signals in which ghrelin and cortisol will stimulate, while CCK, GLP-1 are inhibitory. Leptin is inhibitory. They've got an inhibitory effect, but there are some which will have a stimulatory effects. So all these factors will have effect on your food intake, appetite, and that will be affecting your weight. So there are multiple factors which are working, and even your external factors like emotions, the characteristics of foods, what you take, lifestyle behavior, and environmental clue. All this has got effect on the brain, and that brain gives rise to central signals which can stimulate or inhibit, and that will have effect on liver, GI tract, pancreas, adipose tissue, adrenal glands, all those things. So basically we have got two types of lipids in blood, cholesterol and TG. Cholesterol will give rise to good cholesterol or bad cholesterol, and among HDL we have got HDL1 and HDL2. Among bad cholesterol we have got LDL, TG. TG is converted into VLDL, and there are lipoprotein A, etc., which are considered as bad cholesterol. So we have got three groups: triglyceride, cholesterol, and phospholipids. So whatever you eat from intestine in the form of chylomicron, it is delivered to liver. In liver, you get metabolism, which will convert that into VLDL, and that VLDL is delivered back into blood, and in blood it is converted into IDL and LDL, and then finally converted into HDL. So this will be the cycle. So from intestine it will go to the liver, then to the cell, LDL conversions, LDL will be oxidized, excess of that will be oxidized, and it will be taken up by monocytes converted into foam cells, and it gives rise to atherosclerosis. And HDL will pick up cholesterol and will remove from the body, and this cycle continues. So chylomicrons is absolutely having very low density, so they floats on the top, while HDL is a high density lipoprotein which sinks at the bottom. So it is rich in protein, this is rich in triglyceride, and these are atherogenic, while LDL will float in between and they are more toxic. Increase in number of fat cells will increase insulin resistance. Because of increase in insulin resistance, it will give rise to hypertension, obesity, hyperinsulinemia, type 2 diabetes mellitus, elevated triglyceride, hypertriglyceridemia, which will increase your what we call as a low density lipoprotein, very low density lipoproteins. There are also increase in level of LDL, and there is a low level of HDL. Also there is increased chances of hypercoagulability. All these factors will accelerate atherosclerosis, and secondary to atherosclerosis, chances of different arterial disease like coronary, retinal, kidney, as well as cerebrovascular. While HDL is anti-atherogenic, anti-inflammatory activity, antioxidant activity, anti-apoptic activity, endothelial repair, it decreases the endothelial dysfunction, vasodilatory activity, anti-thrombotic activity, It reverses the cholesterol transport and it increases the cellular cholesterol efflux. So removes cholesterol from the cell and anti-infectious activity also. All this together, it is anti-atherogenic. That's why it is considered as a good cholesterol. This is normal. Monocytes picks up oxidized LDL and it becomes foam cells, collection of foam cells and surrounding fatty infiltration gives rise to fatty streaks which accumulates together and there is a formation of a fibrous capsule we call it a stable plaque, and this stable plaque will reduce the lumen size. Further increase in that will give rise to occlusive symptoms, and that is the time where the person, if it is in coronary artery, person will start getting stable angina or we call angina pectoris. When it is accumulated in your peripheral artery, it will give rise to claudication. More than 50% occlusion, you will start getting symptoms. As it further advances, now if there is a thinning of the capsule, it becomes vulnerable plaque, or if there is a infection of a capsule by chlamydia or herpes simplex, there is a damage to the fibrous capsule, it ruptures, it will give rise to formation of a thrombus and it will occlude. So plaque rupture, fissure, it will give rise to formation of a thrombus. These are called vulnerable plaque and they will give rise to acute coronary syndrome which includes unstable angina and MI. And this MI can be non-STEMI, STEMI, and can also give rise to acute coronary syndrome, can end up with sudden cardiac death. When cerebral blood vessels are involved, it will give rise to stroke, TIA, lacunar infarcts, etc. In peripheral artery, critical legs, ischemia, and even gangrene. As well as it involves retinal atherosclerosis, changes in retinal blood vessels, as well as it will also give rise to renal involvement, giving rise to renal artery narrowing and renal hypertension. So as a complication of atherosclerosis, you can have a CNS involvement, cardiovascular involvement, which will give rise to aneurysm, angina, myocardial infarction, hypertension, etc. As far as CNS is concerned, stroke, TIA, kidney can be involved and it can give rise to secondary hypertension, we call it a renal hypertension, peripheral arterial disease, etc. These are all the different complications. So in clinical actions, elevated level of lipids will give rise to accelerated atherosclerosis and you will get a secondary effects due to atherosclerosis. So always try to identify the secondary cause, and if secondary cause are less likely, always search for primary, because primary groups is only 5%. If you get a very high abnormal elevated level of TG or abnormal elevated level of lipids, say total cholesterol is 300, 400, think in terms of primary groups. Triglyceride level 1000, think in terms of primary groups. And we have told you 2 and 4 are most common. In 4, it will be more of TG. In 2, it will be more of total cholesterol. So that will be the simplified form. For all person above 20 years, you should have a checkup. And every 5 years, they say, I'll say you should have a checkup every year. Even in 45 years, you should have a checkup regularly. And any person who is already a known case of lipid abnormality, depending upon the results, you should have a checkup 3 months or 6 monthly. And Apart from lipid profiles, homocysteine level, lipoprotein A, apolipoproteins, HRCRP, etc. All this should be checked at regular intervals. The most common clinical manifestation is xanthelasma and eruptive xanthoma. This is eruptive xanthoma and these are xanthelasma. These are tuberous xanthomas. This is xanthelasma. This will be seen very commonly in a senile person. We call corneous arcus. Very typical. Arcus senalis or corneal arcus. Classical xanthelasma. These are called xanthoma. This is tendinous xanthoma. It is seen over the tendon. And when these are much more, it is called tuberous xanthoma. You can see those tuberous xanthoma. These are eruptive xanthomas. So tendinous xanthoma, xanthelasma, xanthoma tuberosa, etc. Different diagrams. This is xanthelasma, clear cut, arcus senalis. These are little depositions. We call tuberous xanthoma. This is tendinous xanthoma. This is tuberosa. These are eruptive. You will have to go for lipid levels and you can have even retinal artery examinations. These are eruptive. These are you can have even in the palmar surface. These are xanthelasma. These are tendinous xanthomas. These are eruptive xanthomas. Another thing is very common is diabetes with obesity. We call cardiometabolic syndrome, quite common. And because of this, TG level is quite elevated. So you can come across these two together. We call metabolic syndrome or syndrome X. This I already described. So secondary to hyperlipidemia, atherosclerosis, and secondary to atherosclerosis, all these complications. These are all different complications. Particularly in hypertriglyceridemia, you can have eruptive xanthomas. Because of a high triglyceride, person can present with acute pancreatitis. And you can have a milky appearance in artery and vein of retina, like this, milky appearance. It is very important and can be easily picked up by an ophthalmologist. Where if TG is as high as 4,000, 5,000, these two are very common. So when level is markedly elevated, you can have this, and these are all congenital. This cannot be acquired. Cannot be acquired. Among investigations, history is very important. Clinical examination is important, particularly in hypertriglyceridemia type 4 variety. Person can present with acute pancreatitis. In history, weight gain, diabetes, oral contraceptive pills, person with beta blockers, hydrochlorothiazide, alcohol, hypertension, always look for hyperlipidemia. Also in case of obstructive jaundice, nephrotic syndrome, obesity, cardiometabolic syndrome, they will have abnormal lipids. Always get fasting lipid profile. Look for abnormality in glucose by doing oral glucose tolerance test. Hypothyroidism should be ruled out. Liver function and renal function should be done. Because in liver, obstructive jaundice is very well known, and even in other chronic liver disease also, you can have abnormal lipids. CKD can also have an abnormal lipids. You look for coronary artery disease by ECG, TMT, or you might have to go for MRI angio or CT angio. Also look for renal functions to find out the effect of atherosclerosis on kidney. Fundoscopy should be done, which will be helpful to find out retinal artery atherosclerosis. And also in family, if the person is having a premature coronary artery disease, look for that. So non-fasting lipid level can be done, or a fasting lipid panel can be done. If you get non-fasting lipids, then always look for HDL and non-HDL cholesterol. While in a fasting, you have to look for LDL, non-HDL, and also other parameters. Any person at any age should have a checkup for lipids, particularly more than 20. Ideally, they said that you should have a checkup right from early age groups. Strong family history of lipid disorders, early premature deaths. If person is having xanthomas, or if there is a presence of xanthelasma corneal arcus below the age of 40 years, obesity, hypertension, type 2 diabetes mellitus, thyroid disorders, acute pancreatitis, person having peripheral arterial disease, female on oral contraceptive pills, person who is on beta blocker or hydrochlorothiazide, nephrotic syndrome, chronic liver disorders or obstructive jaundice, metabolic syndromes. In all these groups, you should look for all these factors. We already mentioned this in atherosclerosis. These are the optimum level. This is borderline risk. This is high risk. This is very high risk. Mainly where two levels are being mentioned in a very high risk, LDL more than 190 and TG more than 500. And these are optimum level. Ideal level of cholesterol should be always less than 200. LDL level should be less than 100. In a high risk group, this you have to bring it down below even 70. And HDL should be more than 60. TG should be less than 150. So these are the different figures which you should try to remember and see that they are below this optimum level to reduce the risk of atherosclerosis and complications secondary due to atherosclerosis. So for a rigid control, cholesterol should be less than 150, triglycerides should be less than 100, LDL should be less than 70, or we call 75. Now they go up to 60. HDL should be more than 60, non-HDL should be less than 100, etc. And once you achieve this goal, there is a chance of reversal of atherosclerosis and it should be maintained. These are normal lipids. We say that non-HDL, if it is less than 100 and if it is less than 70, it is considered as the best. But we should try to achieve this goal. Then reversal can take place. Ratio of LDL to HDL. Normal is 2.5 to 3.5. Bring it down below 2.5, that is 2. If you bring it down to 2, then it is good. And if it brings it down to 1.5, means you elevate the HDL to say 60 and you bring down this to 75, then you can achieve this goal. And this will have a very good results. There will be reversal of atherosclerosis. As far as ratio of TC to HDL is concerned, this is usually not considered. Mainly we always look for this ratio, LDL to HDL, and we look at non-HDL. So bring it down to 100 and bring this ratio below 1.5. Then you get wonderful result. TC to LDL ratio normal is 3.5 to 5. Bring it down to less than 2.5. So you elevate HDL say to 60 or say to 75 and bring this down to 100. The ratio will be definitely less than 2.5. So as you bring it down more and more, you will have a chance of reversal of atherosclerosis. Also, the ratio of ApoB to ApoA1, if it is less than 1, it is good. And always ApoB should be less than 20 in normal. So bring it down below 20. So as you bring it down below 20, the ratio will always become less than 1. In an Indian person, this is a common triad which you will see: high TG, low HDL and high LDL. So this is very, very common. And there is one more factor which is there in an Indian, that is increased level of lipoprotein A. These are all the different studies which will be helpful to detect atherosclerosis at a very early onset, or we call as an early stage, that is carotid intima media thickness. Carotid intima media thickness, we short form call as a CIMT, which is done by intravascular ultrasound. Then you can go for MRI for aortic and carotid arteries, coronary calcium score, ankle brachial index, then brachial vasoreactive by ultrasound, vascular complications by doing a radial tonometry. Also fingertip tonometry can be done. These are all the different procedures which are being there, by which you try to identify as early as possible, and these are all the different risk factors which you should investigate and try to bring it down as low as possible. And among this, high LDL, low HDL, diabetic, smoking, CRP, metabolic syndrome, lipoprotein A, dense lipoprotein, then apolipoproteins, strong family history, obesity, stress, etc. All these are numerous risk factors. Some of them are non-modifiable, and you can see here there are more than another 200 risk factors which have been reported. But these are some of the common risk factors. You try to reduce as much as possible. Some are non-modifiable. Say like a strong family history, non-modifiable. Age, non-modifiable. Sex, non-modifiable. And also what we call as a religion or a caste, non-modifiable. So these are all non-invasive measures which you can go for and try to identify the severity of atherosclerosis and progress of atherosclerosis. This is called Framingham risk score, which is commonly utilized to find out the risk of cardiovascular disease or coronary artery disease in 10 years risk score. So 10 years risk score you can find out by Framingham risk score. There are many other different risk scores which are available. Apps are available. You can utilize those apps and find out the risk score. In Framingham, the common things which are utilized is age, total cholesterol, HDL, systolic blood pressure, smoking history, and you add up all these 5, that is step 6, and there is a step 7 has got chart for male and female. You can utilize depending upon the sex, and you can find out the 10 years risk score. Always try to differentiate between primary and secondary and try to identify the etiology as much as possible, and try to find out what type of disorder it is. Management will include diet and exercise, we call it a lifestyle modification, drugs, and among drugs we divide into statin and non-statin. Fibrates are mainly utilized for triglyceride. Nicotinic acid is mainly utilized for elevation of HDL. Ezetimibe is very commonly added to statin for further control and reduce the toxicity of statin, because by that combination you can reduce the dose of both. Bile acid sequestrum are very rarely utilized. So these are the common drugs which are being utilized. So additional support by antiplatelet drugs like aspirin and clopidogrel, blood pressure monitoring and control of blood pressure, lipids management, diet and nutrition, we call lifestyle modification, exercise, etc. So these are all the procedures which are done in hyperlipidemia. Atherosclerotic cardiovascular disorder. This is initiating the statin therapy. These are all the different protocols. If you are interested, at your leisure time, you can go through. I'll just utilize what has been published recently. This was published in 2013 and again revised in 2019 also. It remains nearly same. If there is a person, first thing should be done for all is healthy lifestyle habits for everyone. So lifestyle modification is must for everyone. If the person is more than age 21 and candidate is for statin therapy, if answer is yes, this particular group of people and clinically there is evidence of atherosclerotic cardiovascular disease in that particular group of person, and if age is less than 75, high intensity therapy should be started, and if age is more than 75, moderate intensity therapy should be started. So any person with ASCVD history clinically, then treatment has to be started. Less than 75, high intensity. More than 75, moderate intensity. Or if the person cannot tolerate high intensity, bring it down to moderate intensity. Say person is not having clinical ASCVD. Answer is no. Now look at the LDL. If LDL is more than 190, high intensity is a must. Again, same criteria. More than 75, moderate intensity. Less than 75, high intensity. Meaning of high intensity is you have to bring down all the figures, that is LDL, to less than 50% of original. So if it is say 190, bring it down to less than 100. That is high intensity therapy. Usually we use the two common compounds, rosuvastatin and atorvastatin. In high intensity, atorvastatin 80 milligram and rosuvastatin 40 milligram. While in moderate intensity, you have to bring it down between 30 to 50%. So lower between 30 to 50%. And this in high intensity with a high dose, bring it down more than 50%. So that is called high intensity therapy, moderate intensity therapy. And at a regular interval, you should check. Suppose if the person LDL is normal or LDL is less than 190 but more than 130 and person is diabetic. So if person is diabetic and LDL is less than 190 but more than 130 and age is between 40 to 75, means diabetic person with hyperlipidemia, moderate intensity therapy should be started straightforward. And if he is having risk factor score, ASCVD risk factor score more than 7.5, straightforward, put them onto high intensity therapy. So these are the basics as far as clinical ASCVD clinical findings. LDL more than 190 is concerned and diabetic with hyperlipidemia, age between 40 to 75. So this is the common followed at present. Now suppose a person is diabetic but age is less than 40. For primary prevention, and if the risk factors, estimate the risk factor. If risk factor is less than 5, along with lifestyle modification, you can start with low intensity therapy, and if risk factor is more than 7.5, again you will have to start with moderate intensity therapy. depending upon the risk factors. So always think in that term. This is a combined chart which is given in one single 1, 2, 3, 4 groups. So always it is divided into 4 groups. Try to identify the person belongs to which groups. And these are the guidelines as far as high intensity therapy is concerned, moderate and low intensity therapy. And these are the statins which are being there in the presence of CKD. Usually lovastatin, pravastatin does not require any dose modification. Dose modification is not required for pravastatin only. So you don't require. And for atorvastatin, not for lovastatin, it is atorvastatin and pravastatin. So by and large the atorvastatin is mainly a preferred drug. While rosuvastatin in a CKD you will have to reduce the dose. So in all other, so always atorvastatin scores over rosuvastatin as far as CKD is concerned. In a take-home message, any person with ASCVD, atorvastatin drug of choice. Person who has undergone PCI, again atorvastatin is better than rosuvastatin. Or these are the two common drugs. Prevention of CVD from diabetes, atorvastatin. Low HDL, if person is having low HDL, pitavastatin and rosuvastatin is the first drug of choice. With CKD, atorvastatin and pitavastatin. Person with a very high density lipoprotein, LDL, high level of LDL, rosuvastatin. High severe risk, pitavastatin. If a person has got statin intolerance, again pitavastatin. So pitavastatin is for low LDL, low HDL, impaired glucose tolerance with high severe risk and statin intolerance in these groups. If there is a atherogenetic dyslipidemia, mixed dyslipidemia with type 2 diabetes mellitus, statin, any one statin, particularly atorvastatin with seroclitazole are preferred. And if there is a mixed dyslipidemia without type 2 diabetes, then fenofibrate is a choice. So for hyperlipidemia, diet, exercise and drugs scores over everything. In lifestyle modification, loss of weight, quit smoking, exercise and stop alcohol is a first. So if you do a regular exercise for 20 minutes, at least 3 days per week, you can increase your HDL. If you stop smoking, you increase your HDL and reverse endothelial dysfunction. If you lose weight by diet therapy, physical exercise, pharmacotherapy, behavior or by surgery or anything, you get a benefit. When you combine all this, exercise, stop alcohol, stop smoking, weight maintenance, you get a benefit, increase in HDL, improves glycemic control as well as you get reduction in a blood pressure without any drugs. Good reduction. So lifestyle modification, weight reduction, physical exercise helps in lowering LDL. This is all the different materials in a diet which gives how much calorie you should take in a diet, etc. is mentioned here. At your leisure time you can go through. So exercise, weight reduction, smoking improves in HDL, glycemic and blood pressure. So we say predominantly hypercholesterolemia, statin is a drug of choice. In mixed lipidemia, statin with fish oil and fibrate is a choice. And in hypertriglyceridemia, fenofibrate is a choice. Second choice is fish oil and then come nicotinic acid. We have got three weapons. We always say statin, niacin and fenofibrates. In LDL elevated, statin first, followed by ezetimibe, fenofibrate and then others. In hypertriglyceridemia, first choice is fenofibrate, with statin. In combine statin with fenofibrate and add-on drug niacin. Low HDL, niacin, best is exercise, and then you can add fenofibrate. So this is a combined effect of all different agents. Statin decreases LDL, slightly increases HDL, and it lowers TG. While fibrate will decrease more of TG, slightly elevates HDL, and may have little lowering effect as far as LDL is concerned. Bile sequestrants are very rarely utilized. Side effect of this is it elevates TG. So you have to take care that any person who has got a hypertriglyceridemia, bile sequestrants or bile resins are contraindicated. Niacin will help in elevation of HDL much better. It will slightly lower LDL and also it will take in TG. So it is good in person who has got a low LDL and high TG. So in this condition, niacin is added over statin. So this is a very simple chart which will help you which drugs to be selected in what. Among other anti-diabetic drug, metformin will help additional effect on LDL and TG. Pioglitazone will increase LDL, will have little effect on that. Rosiglitazone, sulfonylurea are not a good drug because they elevate LDL. Rosiglitazone, sulfonylurea, they elevate LDL. So they are not a good drug. While insulin will help in lowering LDL, TG will be lowered because of control of diabetes. So always think in that term. Antihypertensive drugs, among diuretic, hydrochlorothiazide is not good for lipids, beta blocker is not good for lipids, and even alpha blocker is not good for lipids. ACE inhibitor, because of that papar gamma activity, will have effect on lipids, while CCB is neutral. These are all the drugs. You can go for lipid apheresis. You can go for HDL, not effective. Still, lot of research are going on. Vaccines, not yet any vaccines has come in market. Immunotherapy, hot, newer drugs are there. In a person who does not have a control in spite of using statin, fenofibrates, niacin, etc. There are drugs now which are available. They are called as a CETP inhibitors, cholesterol ester transfer protein inhibitors. They are in market. There is another compound which is called proprotein convertase. So proprotein convertase subtilism. So it is short form called as a PCSK9. These are the drugs which are utilized in those particular groups, and there are newer compounds which are coming in market like apolipoprotein B synthetase inhibitor, microsomal triglyceride transfer protein inhibitors, and thyroid hormone analogs are in markets. These are the complications secondary due to atherosclerosis. So I thank you all for taking out time. I know your time is valuable and I appreciate that you have spent some time of it with me. So I say goodbye to you. Hope this lecture will be helpful to you and it is a very useful lecture.